So greetings, we will be going through neurodynamic testing for the maladaptive pain patients, and this is mostly for the occupational therapist. So what I did is I sectioned it off. I did an upper quarter, which is mostly going to be the upper extremities from the shoulder all the way down to the fingertips. Our objectives, and number one is learning the upper extremity nerve pathways, and what I did is in the handouts I went ahead and made links to show neurodynamic testing and being able to palpate and locate the areas where you'd be able to find your median nerve, ulnar nerve, and radial nerves. There's also going to be slump testing. Most of the time OTs, I'm not sure if all of them use it, but there are some that have been familiar with it to rule out anything that's going on at the nerve root level or at the dural level. Pain pressure thresholds, we'll go through some of that with a pain algometer. Hot-cold testing, body recognition of the upper extremity, self-localization, two-point discrimination, grid localization, vibration senses, and finally left and right discrimination. Now, the way that this is all set up, it's not necessarily in order of most important. So there's a couple of them that I really want to focus on if you don't have time to test all these on your patient. Now, the three areas that we end up testing are the median nerve, the radial nerve, and the ulnar nerve. And we're going to test that all the way from the brachial plexus. On the handouts, you're going to see the areas where you're going to end up palpating the most. So real quick, we can go through all this. The median nerve is going to be in the upper arm, midline of the axilla to the biceps. So right here. And it's going to be medial to the biceps tendon. Here, so I don't know where the biceps tendon is. It's right over here in the bicipital groove. It's going to be just right there. And all the way down to the carpal tunnel. So it's going to go all the way down to the carpal tunnel. Now, next one is going to be the upper extremities, the ulnar nerve, and it's also going to be in the upper arm, inferior aspect of the upper extremity, and in line with the axilla and the cubital tunnel. In the cubital tunnel, however, there's more sensitive. It's much more sensitive once it exits the branches. So the Goyon canal of the pisiform bone and the medial hook of the hamate. Right over here is where it ends up terminating into. So right around here and right here, these are going to be the most sensitive areas of your ulnar nerve whenever you're testing that. The radial nerve, it's going to be radial spiral groove, the arcade of Frosch, anterior aspect of the forearm and crossing over to the snuff box. So it's going to be on the lateral side of the arm. So active neurodynamic testing, I usually begin with active testing and have the patient go through the motions of median nerve, and I usually would just tell them, hey, is this something that is comfortable for you to do or difficult for you to do? And if they tell me that it's difficult for them to do and it provokes their symptoms, then I go ahead and do passive testing and have them lay down on the mat. Radial nerve, the same thing. What I'll do is I'll have them just bring up their hand behind over here, and if they're producing the signs, then I go ahead and manually test that afterwards, passively. And ulnar nerve, I usually will have them just do this position over here, and if they are saying that that's part of their symptoms, then I go ahead and test that. So once again, all the passive tests, those are going to be on the handouts, and I'm not going to go through too much for that. Slump test, I begin, once again, just like the upper limb tension test, actively. So I have the patient go ahead and slump forward, and I ask them, hey, is looking down, is looking up in a slump position, does that produce any of your symptoms? And if that doesn't, then I go ahead and include the lower extremities for plantar flexion versus dorsiflexion to see if there's anything that comes up in their symptoms around their neck or their shoulder with a straight leg raise test. So it's basically like a straight leg raise test, if you're familiar with that test, in a sitting position. So pain pressure threshold, I usually use an algometer, and this can be located on my desk for anyone that ends up needing to use something like that. Any of the pressures below 4 kilograms usually indicates increased sensitivity of the nervous system. What you want to do is you want to test as close as possible to the test site, and those areas we're talking about when we're palpating for the pathways for the median nerve, the ulnar nerve, and the radial nerve, you want to be able to palpate those areas and test on those spots where it was indicated. And if those areas are too sensitive, somewhere just lateral, medial, or around that area is going to be able to be a good place to test. So if you can't find the spot, or if the spot is too sensitive, use the neighboring sites. Now this helps me indicate if this is sensitivity that's peripheral neurogenic versus something that's central sensitivity if I end up testing for a remote site. Now, when I say by a remote site, let's say you're testing the median nerve because you're finding that that's very sensitive in that area. But you also want to check to see if there's some central components that may be affecting this patient. So what I do is I look for a remote site. I ask the patient to tell me, hey, does your left leg hurt? And what about your shin? And I'll do this before, and I'll do it after an intervention, an exercise, or an activity. And if their pressure algometer scores are increasing, and that means they're becoming less sensitive to the activities that they're doing. And I like the things that you get early on, because what happens is all the information I receive early on are great indicators of how the patient's going to end up responding or reacting later on down the line. So MCID is usually about a 15% improvement, and if you're finding that change, then you're heading in the right direction. Hot or cold testing, a lot of times, what I'll do is I'll ask the patient if they are feeling either pain or their symptoms when they have a cold pack placed on the spot that they have a lesion or they have an injury. When they say that that's painful versus, hey, that's cold, then it's a positive test. Heat works exactly the same way. I usually find less incidences of people who are more sensitive to heat versus cold, but it is possible. Body recognition of the upper extremity. I usually have the patient draw a diagram of their upper extremities to determine if smudging has occurred. So sometimes what I'll do is I'll end up starting off the diagram. I'll draw their head, I'll draw their body, and I'll draw their hand. And if, for example, they have an injury at the elbow area, I'll have them draw that section over there.
Something like this. And what I'll do is I'll have them draw what it looks like. And sometimes
so you would have them draw a hand, and then you'd put the head on there and ask them to draw the hand on the body.
I sometimes ask them to draw the area that's painful over here. And the reason I draw the head and the hand is because I try to sometimes give them a head start. Sometimes it takes them they're a little shy in being able to start drawing something like that, or their body maps are so distorted that they actually can't feel, or they can't have a sense, and they don't know where their arm is. So sometimes I'll get body maps where people will draw, here's their body, and they'll draw their legs, and because they can't feel this area over here, it's no longer a part of them. So sometimes I hear sentences.
That's like strokes.
Yeah. Yes. Yeah. It's going to be quite similar to something like that, to where they've lost a hemisphere of the body and they don't recognize its existence anymore. Yeah.
Now, self-localization. What I do is I have the patient close their eyes, and I try to have them find sections of the arm. Sometimes I'll test to see if they're checking, can you point at your nose? Can you point at your forehead with your eyes closed? And once they have that down, if they're able to find, okay, where is your thumb? Point to that. Where is your wrist? Where is your elbow? Where is your shoulder? Where's your bicep? And the MCID on that test is about 80%. So 8 out of 10 is usually a passing score for self-localization.
A lot of times patients will also mention that, why am I even doing this stuff for? And the reason you're doing it is because the people we find who have a sharper sense, a clear body map of what's going on, have greater chances of being able to reduce their pain. If I was in LA and my phone goes out, my GPS goes out, and all the streets are all one way over there, and I'm running 15 minutes late, I tend to stress out and ramp up my own nervous system. But if I have a clear map and I know where I'm going and I'm on time, usually everything starts calming down a little bit more. So the body ends up working the same way when it starts losing its weight and when it starts disowning or disconnecting with parts of the body.
What you want to do is you want to be able to have enough pressure when you're testing two-point discrimination, and I usually use a caliper, a plastic caliper. And you want to be able to blanch the skin, so you want to watch the skin color at least change a little bit. This way you can stay consistent with how much pressure you're placing on the patient. You want to start at 0 millimeters, and I tend to start a little bit larger than that because in a clinical setting you might not have as much time to start at 0. I'll sometimes start at whatever the norm is. So for example, on the hand, I want to start off with about 10 millimeters, And if they're able to tell me that, they felt 2 points, then I can go smaller. But if they're telling me that they're still feeling only a single point at 10 millimeters, what I'll do is I'll go 11 millimeters, 12 millimeters, 13 millimeters, and I've actually had somebody go all the way down to the forearm over here. You want to make sure that the patient's not able to see what you're doing. They're either looking away or you're covered in a way that they can't see what's going on in their hand. This is going to be the most important test you want to do. So you want to make sure that you get to this test. If you have no other time for any other test, this is the one you want to do first. Now, grid localization, you're going to notice that if you're looking at the hand, we started breaking down the sections of the hand into 6 segments. And you want to just sort of poke with the back of the ballpoint pen and tell them, this is grid 1, this is number 2, this is number 3, this is number 4, this is number 5, and this is number 6. And what I do is I end up having them look at the picture of the hand. Therefore, they can at least have a map for them to be able to go by when you're pointing out the areas of their hand. So if they tell me that, okay, that's a number 1, okay, wait a minute, that feels like about a number 6 right there. That feels like about a number 3 right there. Vibration senses, high and low discrimination, is what I sometimes use when I have either a 128 hertz or a 256 hertz tuning fork. They'll sometimes be able to tell me, oh, that feels like a low vibration, or that feels like a high vibration. And what you want to do is you want to be able to strike the tuning fork and place it around the area that you're suspecting has allodynia. If it's painful with vibration senses, they'll tell you, that doesn't feel like vibration anymore. That feels like painful sensations. That feels like exactly what I'm suffering from. So this would be positive for central sensitization. Now, last but not least is left-right discrimination. You actually want to start with this test, and we'll go over that later on in the treatment part of it. But you want to start with left-right discrimination because you want to be able to find out if the patient has crossing over. And when I say crossing over, the brain is now confusing the left side and the right side. And some of the symptoms that were being produced on the left side, for example, if this is a focal area where that had some injury in the past, and the pain continued to persist a couple of years later, sometimes what happens is the left side symptoms will start spreading over to the right side, and the right side will start mirroring what's going on over there, only because the brain no longer can determine which is left and right, and it's sending the warning signals that normally would be coming from the injured side over to the uninjured side now.
So this concludes our assessment on patients with very sensitized nervous systems. Now we can move on to the treatment part. Here are our objectives.
Now, I've been told that this stuff sounds a little bit funny and it sounds a little bit wishy-washy. So most clinicians, and actually I get this more from patients, is that a lot of patients that aren't familiar with something like this because it's still fairly new in its infancy and being used in the clinic, how well does this work? And my short answer is usually yes. I like showing them this slide over here.
Yeah, so number needed to treat, like I guess with gabapentin. So for every 3 patients that we see, we're only going to have 1 out of every 3 patients that ends up successfully doing well with something like this. So, and then even with function, that's for pain. So for every 4 people that we see, or 3 people that we see now, I think it's getting a little bit better. Only 1 of those people are going to end up becoming successful in being able to reduce their pain. Gabapentin, and this is the top of the best that medicine can offer, is 6 to 1. So I'm going to say that when they give them the gabapentin or the antidepressant,
out of 7 patients
SSRIs,
or 6 patients, 1 will benefit.
Yes.
Oh, wow. And antidepressants is even less. Success.
It's even less, yes. And that's the best that medicine has to offer.
About the kind of
Yes. So it gives me a little bit more confidence that thinking that, some of the stuff that I'm doing is better than what the medical doctors' outcomes are doing right now by a whole lot. So even though people mention
like it's confusing and it's weird and it's different.
It's different. It may be, but it may be all that. But at the same time, it seems to have better outcomes than what they're offering too. So I don't mind it anymore. These are some of the things that end up, some of the phrases that come up in here. So any of the times we've used phrases such as this on the left side over here, we found out that it starts to fuel nocebo effects, or this is language that
these
we end up
aggravate.
using. Yes. So some of the things that come up are sort of shocking, and I've had to literally change my language to something that was less mechanical when trying to describe to a patient when they ask me a question like, okay, so what about the disc in there? You know, what is I've got a bad disc, and I usually tell them what's really nice is that every time we look at an MRI in the last 20 years of collected data, that the worse a disc is and the worse degeneration towards bone and bone contact, worldwide we've had people that report less pain with more degeneration that's come up, and it's usually just a little bit of degeneration or medium amounts that people have the highest reports of pain that go in there.
Why is that? Why do they suppose that?
Well, is that because because over time does it kind of wear and tear to where it becomes a better
we're thinking that
joint surface or something?
that's the key. It's an over time thing.
Yeah.
Stuff that happens over time allows the body to be able to adapt well to it. It's when it's maladaptive that it ramps up the nervous system to create a lot of emergency signals to get sort of transmitted out.
Interesting.
So, and I've even had a patient mention to me like, they say it's the worst hip I've ever seen, which, by the way, that statement can actually ramp up a lot of anxiety.
Right, sure.
Other things like that, or I've never seen something dislocate out that far before. You know, so those are the
I'm
dangers.
going to have trouble with this rest of my life, aren't I?
and not necessarily, but sometimes maybe yes.
So this is a review from the last in-service, and I usually like using the Smart Blake CPR as a guideline to determine which kind of education I end up providing to my patients. So a lot of times if they're more nociceptive and the injury is fairly new or they just had a recent surgery, I won't necessarily go into P&E a whole lot, only because this crowd and population may not need it as much. So I always think that everyone needs P&E, but the difference is that this crowd over here might need 99% treatment, go on with it, and they might only need about 1% P&E. Now, the peripheral neurogenic crowd, when the people that fall into that category in the Smart Blake, outcome, those are the kind that need peripheral and central sensitivity, or the central nervous system plus the peripheral nervous system. And the more that they know about this stuff, and the more that they know how biology works, and that the body is actually there to protect them, and that pain is actually there to protect them, versus try to harm them, I think the more they're going to be willing to move for you. This is really important, is that the movement is necessary when going along with the P&E. So you want to do P&E plus the movement, and the P&E is what's going to create an environment so that they're going to feel safe to make those movements along with it. So this is the left-right discrimination, once again, the flashcards, and this is what I was talking about earlier. You can get this on Android or an iPhone app, and Orientate is the free app, whereas the Recognize app, the one I purchased, you can get for about $7 each body part. So I know they've got one for the shoulder and they've got one for the hand. So those two areas for occupational therapy might be very useful. Either make or purchase flashcards that will have the hand in there. The patient is going to have about 60 seconds to be able to perform this test. And what they want to do is they want to go through a stack of cards and be able to place them on a table that is marked either left or the right. Left or the right, left or the right. And they'll have about 2 seconds to be able to go through these cards. So 80% accuracy is what they're looking for before you can start progressing to the next level of this activity, which would be turning it clockwise about 90 degrees, and then clockwise again 90 degrees, so that if you're looking at it, it would end up becoming 180 degrees all the way around. If they don't have a phone, if they're not tech savvy, what I have them do is as a homework assignment, they take off with one of our magazines in the waiting room, which I know they're not supposed to do, but if they don't have a People magazine, and I like People magazines because there's a lot of body parts and a lot of people that are in there, that all they can do is they can end up circling all the left hands in there, all the elbows that they can find, all the shoulders that they can find as quickly as possible. And when they get really good at that, what they can do is they can go through it again. They can circle all the right side now. And what they can do is when they get really good at that, they can start turning the magazines over. 90 degrees going clockwise. If they get really good at that, 90 degrees going clockwise, getting really good at that, and continue to go on. So what will happen is that when they come back to the clinic and I end up testing them one more time, they should have a much clearer brain body map and homuncular map, so that when I test them, they should be able to hopefully get 80% on their left-right discrimination. This means they can move on to the next activity for you. Now, graded motor imagery, once the patient is able to do left-right discrimination, and once they're able to find or get about 80% accuracy, they can move on to graded imagery, and basically this is exposure. If they're not able to physically do the activity, they have to actually imagine a lot of the exposure. Now, a lot of this ended up happening, I think, from mostly athletes who sit there and imagine running through the hurdles. So each of these athletes actually know the amount of steps it takes to go all the way around a track in the Olympics, and they know exactly which hurdle is going to be the left leg and which one is going to be the right leg, because they envision it and they've gone through it in their heads thousands of times even before they end up running something like this. Now, the more they're able to do something in their mind and the more they're able to do it safely, if it's not causing any flare-ups, then they can start actually doing the physical activity slowly. And even if that's too much for them, they can back off a little bit and they can actually watch somebody do the activity for them. So great example of this is that I had a patient watching me kneel down because watching me kneel down was hurting her knees. So what I did is I ended up exposing her. Okay, what we're going to do is you're going to watch me kneel halfway down. I'm not even going to touch the pad where I'm going to kneel down. I'm just going to kneel halfway down, and then I'll come back up. So after about 3 repetitions of that, we were able to go down a little bit further because she realized, you know what, that really wasn't very painful. And when I tried it again, going all the way down to my knees, I was only able to do it maybe one time. The second time, it started causing her knees to become painful. So she was able to go ahead and tolerate 1 repetition of watching somebody else do that activity. So she can do this watching YouTube videos of somebody kneeling, or one of the family members can end up doing something like this also. Once she's able to do that, she can expose herself to another 1% to 10% of this, and she can try going. She can try having somebody kneel in front of her, maybe instead of 3 seconds the first time, and then 1 second the next time, and then 2 seconds on the second rep, and then eventually 3 seconds, and then go on to 2 full 3-second reps of kneeling, and then a third repetition of 1 second, etc. So she'll be exposed, and usually if your brain and your nervous system absorb small bits of information like this, it can adapt much easier than just dumping a whole load on top of it all in one shot. So make sure that the patient is in a comfortable position. You start with static positions, going on to dynamic, and then them actually doing the tasks. So when they finally get to do the tasks, I'm going to have this lady kneel down one time, halfway down, just like I did, 3/4 of the way down, and then basically kneeling down on a stack of about 5 or 6 pillows, just a gigantic stack, so that it's going to look like the fluffiest thing that she could never possibly kneel down on. Now, I've been successful with this maybe just 2 times previously, and the person that I was most recently successful with, she hasn't been able to kneel down at church for over 20 years. So after doing something like this, she was able to kneel down for just 1 prayer when she was at church, and that's all she could tolerate. But it's been over 20 years since she's been able to do something like that on her knees. The biggest thing that she wanted to try doing that again is because she felt like sort of an oddball. When everyone is kneeling around you, She said that you sometimes look like you're the sinner because you're the only one sitting down and not kneeling with the rest of the congregation. Sensory motor discrimination, localization, and graphesthesia. This is the 2-point discrimination that you want to continue testing with. Now, once you've tested the patient, you can use paper clips. Let's go through that right now. And you can get a ruler and some paper clips. And you know, there's an article, and I basically posted that on there, just a snippet of the abstract, that whether you use calipers or whether you use paper clips, it actually doesn't matter. The only difference is that the calipers can be adjusted more rapidly. When I find out what the person's 2-point discrimination is and what they grade at, and it's at 15 millimeters, what I'll do is I'll find 2 paper clips, one that goes 5 millimeters above and 5 millimeters below. So one will be set at 20 millimeters, and the other one will be set at 10 millimeters. So what they can do is they can sort of toggle back and forth between those, between the paper clips. You know, one that they were able to get it at 15 millimeters, one at 20 millimeters, and one at 10 millimeters. So eventually, as they're able to find and distinguish the different sizes, I'm hoping that they can eventually get more consistently 2 points, 2 points, 2 points registered at the 10 millimeter mark. You want to be able to determine what feels like a pencil, what feels like a pen, what feels like a paper clip, what feels like a cotton ball, and you can start creating and building your own lists from old clothing like jeans, materials. And when you're doing something like this, I know that I've watched people in the fluidotherapy machine just sort of sifting through the sawdust, and just enjoying the warmth that's in there. But when you find things that are much more precise, something that the brain is thoroughly involved in and immersed in completely, like looking for letters of the alphabet that may be hidden inside the sawdust, and being able to determine, okay, that's a letter W, that's a letter Y. Being able to determine, you know what, that feels like a plastic guitar, that feels like a plastic fish. Once they're able to figure out something like that, then it paints a much clearer homuncular map. So once again, you're doing this for the purpose of seeing if you can get the 2-point discrimination to become smaller and smaller and smaller and much more precise. So sensory motor, so graphesthesia, this is the alphabet, and what I do is I end up going through the alphabet on somebody's hand, on somebody's forearm, and you want to make sure you orient the alphabet and the letters toward them. In the beginning, what you want to do is you want to actually draw the letters and tell them that's an A, that's a B, that's a C. Get them familiar with how you write the letters, because everyone and every therapist writes letters just a little bit differently. So to be fair to the patient, you want to be able to make sure they get it with a little bit of a cheat sheet before the test. 70% to 80% success is actually still important for me, because the reason I chose 70 to 80% is because it keeps the patient motivated in wanting to continue with something like this. If they get 100% every single time, 100% each time, you might be drawing the letters too big. And what's going to happen is it's going to bore the patient. You know, you don't want to be right all the time, but at the same time, you also don't want to keep getting things wrong all the time. So if you're getting only about 20% or 30% accuracy, it may start to frustrate the patient. You want to be able to change the size. All right, mirror therapy. This is going to be treatment sequence number 5. And this was, I guess, noticed because what happened was one of the scientists went in and started eating a banana, and when one of the monkeys that was still connected to the machine saw the scientist peeling the banana and eating the banana, it got exactly the same neural maps lighting up in the brain as if they were eating the banana. So 25% of our brain is made up of mirror neurons. And what happens is that when you watch a football game and you see somebody score a touchdown, the reason you get excited and the reason you feel like you're the one who just scored a touchdown is because 25% of your brain actually did just score a touchdown. So we have the ability to be able to make connections even through media like a television. It still works, and it still works like that. So when you're there and you're seeing the other hand going through the motions, you try to replicate what the other hand that's not able to move quite as well Or sometimes if you're working with an amputee, you're working with a limb that no longer exists, that they're seeing again for the first time. So you have to be careful with mirror therapy because it can be quite an emotional roller coaster for people who may not be emotionally prepared. So sometimes you have to tell them right off the bat in the beginning, this is going to feel a little bit funny. This is going to feel a little bit weird. But if you buy into it and you look into the mirror and you see your other hand and you see all the motions it's able to do, and your brain is able to get completely immersed in the entire situation, then this is going to work out really well for you. But at the same time, I want you to also prepare yourself emotionally, because it might feel overwhelming, being able to do all that movement again. You can build your own mirrors, and you can do it for, I guess, a fairly low price, or you can actually go online and there's mirror boxes that you can purchase. All right, so that concludes everything. I tried to go through this as quickly as possible. I know this is approximately an hour and a half's worth of stuff that I tried to condense within about 30 minutes period of time. And if you have any questions, my extension is 12437, or you can also email me, and I'll post my email over here on the video.